Welcome to This Just In, the show bringing you the latest advancements in healthcare, strategy, innovation, and public policy. And now, for the fastest voice in healthcare, here's your host, Justin Barnes.
Thank you for tuning in and welcome to This Just In. I'm your host, Justin Barnes. In these segments, I'll bring you the latest advancements in healthcare, strategy, innovation, and public policy. This week, we're broadcasting live from This Just In studios on the Healthcare Now radio network and also decided to broadcast live on LinkedIn today. We hope to continue these live broadcasts on LinkedIn once a month or so. It's a great platform to collaborate, have phenomenal guests, and then show everybody kind of a behind the scenes and how we do this. And again, behind the scenes, this is a true scene here. It's the Sarasota Bay, Gulf of Mexico right there. We'll dive into that a little bit too, because we've had some pretty bad storms down here, but always fine. Studio's great. And everything here in Sarasota is always phenomenal. But for this episode, my 301st episode, we decided to broadcast via LinkedIn Live again, because we actually received the award for 2024 Podcast of the Year. And here it is. Very happy to have it. It's actually on my counter every day. I'm truly grateful and blessed to have received it. And I want to say thank you so much again to Sway Health and the entire healthcare and digital health community that voted us number one. We could not, again, be more honored or grateful. And I want to say, another shout out to John Lynn, Colin Hong, and the entire Sway Health team. And for those that may not know, Sway Health Live is a premier digital healthcare and health marketing conference in North America. I highly recommend it. Every June or so, they have a great annual conference. And also, I want to say thank you very much to all of my previous This Just In Radio show guests through the years. This show is because of you. You made the show number one. And certainly also many thanks to my producer, Roberta Moen, and certainly the entire Healthcare Now radio network staff, and just amazing people over there that help us every single day as well. Launching the show 10 years ago was actually Roberta's idea, and I'm certainly glad I listened to her. So now on to this show, and the reason why we have this 301st episode, I wanted to host an insightful and thought-provoking discussion on chronic care management, care strategy, value-based care best practices, and also how to successfully navigate the future of healthcare. I know this may sound complicated, but that's why we wanted to host this show, talk about a few simple steps and strategies that anybody, any care provider, even patients, but also provider organizations all can implement to be successful. It's really important. We'll talk about some of the big numbers, what this means to everybody, us as Americans, us as patients, us as providers, organizations, what it means to each of us, because it truly is historic where we're going in a couple of different directions. Before I go any farther, I want to introduce my very special guest, good friend, and a very familiar voice to the show, healthcare strategist, writer, and thought leader, Mr. Greg Fulton. Welcome back to the show, my good friend. Where are you calling in from?
Thanks, Justin. Appreciate it. I'm in suburban Atlanta, where we have no real body of water anywhere near us. I used to live in Tampa, though. Can you see the Sunshine Skyway Bridge from there? I used to go over that.
Right there.
It's right over there on the side. All right. We'll have you turn the camera later. Thank you for having me. I'm happy to be here, especially on this topic. And I know this is a topic that's near and dear. I'll actually try to open the show and ask you one or two questions, or a two-part question. Wow. I know you've been advocating for chronic care management really since the codes came out, 2015. Yeah. And A, why? More so, B, are you able to keep the faith? I mean, you're about to cite some daunting numbers on chronic care management and our healthcare spend, and you're keeping the faith all this time. How? Why?
Great question. And you and I kind of worked on this. Greg and I have worked together, know each other for almost 20 years now. And it's just, A, it's the right thing to do. You always kind of, as something I live by, you always do right. Number one, we need this in our country. We have a healthcare system that, it may feel great to a lot of us. It probably doesn't, to be honest. I'm trying to be positive and optimistic, but we don't think that we don't have, when you look at the stats, we don't have the very best care in the world. And we just got to really look at where we are as a society, what we deserve kind of as patients, but also we're paying for all of this. So my passion comes because as taxpayers, this is us that pays for all this, and we don't get really what we love. So why not look for solutions? Let's look at a higher quality of care that we can receive, a better value for what we're buying, and also make people happy. Doctors got into this business to care for patients, not run a practice. So let's get them caring for patients and providing the very best care. They want to provide the very best care. It's what's in their heart. That's why they went to medical school. That's what they, studied for 8 to 12 years, some of them. It's near and dear to them. It's near and dear to us. We pay the bills as patients. We also, as patients, want this type of care. And we also want a system that's sustainable and at a current pace that we'll get into these numbers. It's not. So number one, that's where my passion, my energy comes from. And also, you and I have always worked kind of on the white knight, doing the hard work that nobody else wants to do, talking about the topics that nobody else wants to talk about that may not be sexy or exciting. But to us, it's in our heart. It's what we love to do. So that's where my passion comes from, my friend.
Yeah. I mean, in chronic care management, we've all seen the codes. We've seen code expansion. We've seen CMS increase the fees for the codes, rare in the fee schedule. We've seen the launch of new codes, principal care management, behavioral health integration. We saw last year that CMS finally married up or merged some of the remote monitoring codes and the chronic care management codes and brought in FQHCs to allow concurrent billing, same patient, same month for the care management aspects of these codes. So we're seeing over time the increase in the opportunities. Now, like you say, we'll transition to value-based care. How can you take chronic care management and value-based care? There are ways, but I know we'll talk about that a little bit. But I won't interrupt you any further because I know you want to get those numbers out that again, why we're really here and what's in front of us on chronic care management.
Yeah, no, and I appreciate it. And absolutely. And you and I have actually co-authored a blog piece that we'll put out there, and a thought leadership piece that we'll put out there, really concurrent with the broadcast of this, certainly in the coming weeks. And also we're going to do a series. It's going to start off with, how and why chronic care management is the glide path into value-based care. A last piece that we actually did previously was talking about this, how they finally allow these FQHCs and RHCs to build these multiple billing instances, which is critically important for them. But also, what's really important is that we get this out into the specialists as well. That these different specialist organizations, they implement it. So it is great for a lot of these organizations, FQHCs, RHCs, general practitioners, internal medicine, family practice, great. But now let's start looking at the specialists as well. And so you and I are going to actually do a series on that. I don't want to jump too far ahead. However, for all of these constituencies, this is a natural glide path into value-based care. Fancy term. All I'm saying is it's the glide path into the future of healthcare. So that's what I'm most excited about. And that's why we want to do these shows. We're going to do these shows on a regular basis. We're going to produce these thought leadership pieces so we can get the word out there for people to start looking at it. What does it mean for you as a provider? And we'll even touch on some of the patient aspects, but what does it mean as a provider or a healthcare organization? What is a great next step? I think on my last show, literally just mentioned roughly 7% of care providers have embraced chronic care management, any type of chronic care CCM strategy. So we have 90% of the market still to go of care providers to engage these types of programs. So it is really important. But I also know you can start at any point and begin to be successful. The bar is very low, 25 plus codes out there for you to navigate today. As Greg mentioned, more coming. These are all building blocks, and it's not too late to start. Like I said, you're part of the 90. If you haven't started yet, you're in the 90%. Now, it'd be great if you're in the 7% or 8%, but anyhow, I think that's why I want to do these shows. We're going to do these shows more often. We're going to keep this topic top of mind. But before we dive in further, what would you like to add on to that, Greg?
I would add on to that let's give some credit where due to CMS and policymakers for expanding the codes and the fees, merging up concurrent billing with remote monitoring codes. Let's give them credit for that. Let's hope that, and the concurrent billing, same patient, same month, separate 20 minutes, began in January of this year. Here we are only about halfway through the year. Let's see where utilization goes now that you can do that with the code sets. Keep in mind also, everyone, if you're not familiar, the chronic care management codes can be done general supervision, just like the remote monitoring codes as well. That means clinical staff, that means scale, that means business model. How can you build that? Now adding in other codes for concurrent billing. What can my general supervision billing model look like? How can I scale up that way? And then, as we'll talk more about today, how do you then transition into value-based care? Does CCM and value-based care go together? Well, there are some ways that they do that we want to talk about today to just keep further nudging or pushing or seeing the possibilities. Because again, the numbers you cite on the healthcare spend, or that you can cite on, how much of our healthcare spend goes to chronic care management and mental health. Well, there's a new CCM code for you called behavioral health integration. That's just a few years old. So again, as you put it, puzzle pieces, put them all together, foundations. But, value-based care and CCM, how could that be? We'll talk a little bit more about that. So I would just reiterate that over time, the possibilities are there to get those numbers up and get those providers into CCM. And there's a little bit of a carrot and stick when it comes to quality programs that we'll talk more about too.
Yeah. So, jumping off there a little bit, because again, going kind of the big picture, and then we'll kind of dive in, and this is what you'll see in our thought leadership piece coming up. But the CDC reported last month that 90% of our annual $4.5 trillion spend, not million, not billion, trillion, 4.5 trillion, 90%, so almost $4 trillion of our healthcare spend is devoted to people with chronic conditions. That's much larger than anybody's talking about right now.
Yeah,
that's significant. So
just seems staggering, right? And you said it before. I watched your last show. You said you're on your last show about chronic care management. We also know that Medicare patients, 70% of them have 2 or more chronic conditions. So start putting the numbers together, start adding the numbers. The patient population is there. The reimbursement programs are there. Scale, business model, it's there. We've heard about value-based care for years and years and years. Again, how can this translate into that to try and get more motivations in to embark upon this?
Yeah. So now let's dive into some of the nitty-gritty that we'll share in our thought leadership piece as well. And this affects all of us. Again, we are all patients. We all pay this bill as taxpayers. We pay this bill. And also, my passion comes from the quality of life. So quality of life as a patient, quality of life as a citizen, quality of life as a provider. Again, we're all in this together, and that's why it's critically important. And we're talking real numbers, $4 trillion. We can make a difference. A small dent in that increases care quality, increases quality of life, reduces the debt that we have every single day. So those are just a couple quick pieces. But let's dive into MIPS and value-based care, because I think that's where, and I know ACOs touch on that, but a majority of my listeners, well, I got some ACOs here too, but the MIPS is where the significant majority of care providers are going to fall into that bucket. It is mandatory unless you're exempt for one reason or another. But let's talk about that for those that it's mandatory, and why they do it. So I'm going to talk on the number that I touched on last time. Then I'll have you dive in and talk about specifically some of those measures and how it's a glide path for value-based care specifically. But when you look at what the why we should be doing CCM, even if you say, hey, I don't want to think about, I don't want to talk about value-based care, do it because it can offset the cuts that happened in 2024 with the physician fee for service schedule, the 3.4% cut. And then they also cuts now much smaller every single year coming. So even if you don't care about the future where healthcare is going, and say, I want to retire, do it today, because it'll help you basically make up the money from the cuts that happened inside your fee schedule. And then also schedule every single year for the foreseeable future, the cuts coming to the physician fee schedule. So that's just an offset on that one to think about yourself, but at the same time, you'll be helping your patients. But Greg, why don't you take us into the whole MIPS piece?
Sure. Yeah. Not only that, but what if you're getting penalized in MIPS? How can you overcome if you're getting negative penalties in MIPS and you're getting hit by the fee schedule? How can you overcome all that? So take a step back. MIPS, no one's favorite quality reporting program.
No one.
As part of the QPP, or the quality payment program, we know about it. We know Medicare started this many years ago. As you just touched on, or you just mentioned, every physician with Medicare patients is subject to MIPS quality reporting, unless, as you say, there are exceptions. One is you're already in an advanced alternative payment model. So if you're one of the few in there, bully for you, because you're a little bit ahead of the game. Value-based care lies there too. Otherwise, if you have less than 90K billing, or if you have less than 200 patients, you can exempt out of MIPS. That leaves a wide swath of doctors subject to MIPS. I think AMA said that about 300 plus thousand are looking at penalties in 2025 already. So MIPS, the merit-based incentive payment system, quality reporting, you're subject to it. 4 categories you report into. You pick your measures. In the quality measure, there are 200 measures you can choose from. And as the documentation that we're going to be put out will say, there are 33 measures that line up with chronic care management. There are 22 high quality measures that line up with chronic care management. What are they? They're pretty self-evident if you look through. Chronic disease management, duh, that's a measure. Patient engagement, that's a measure. That's part of chronic care management as well. Care coordination, all of those things, very simple that you can do. And if you set up the program where, you take a step back, I want to do chronic care management, or I am doing chronic care management, and I see the codes and I can scale and I have general supervision. Do I want to start reporting that into MIPS and just start getting my feet wet in value-based care? Because if I can show it internally that I can actually conduct a chronic care management program. I've got my electronic health plan. My patients hit the numbers, they hit the criteria. Look at MIPS as I won't say painful, but as whatever MIPS means to you, take a hard look at it, because it is a starting point where you can take chronic care management, you can report into quality, you can see that as a value-based care program, you can start to show results. And to Justin's point, you can start to make a difference there, and you can scale, with the way the codes are constructed. So I would take a hard look there. MIPS is not going away. It's going to stay in that program if you are subject to it. And I think here's a way that you can, I would say you can triple dip in terms of, I've got new codes, I've got concurrent billing. Now I've got a way for quality payments, and I have a way to maybe turn around any penalties I'm getting, so on and so forth. I'll stop there and we'll talk a little bit more about what do you do post MIPS, or once I'm into MIPS and I'm proving it, where do I go from there?
Well,
but those are really the basics of what the MIPS program looks like.
Thank you. I love it. And I think what's really important is for people to understand there's real money here. So, the average provider that I work with, been fortunate over the last several years, roughly $13,000 per month per provider for just performing very basic chronic care management, CCM type measures on their patients, and really just monitoring their patients in a very simplistic way. So it's real money. It's, for you get 10, 15 providers in a group, that really adds up, even 1 or 2 providers in a group. And that's on average. I have some providers in my network that they'll make an extra $60,000, $70,000 per provider. But they're obviously got a very unique care strategy, but it works great. And they're paid. And also what this means for the patient, this is actually a company that came across actually in Tampa, in your old backyard, called Uplift, that they can, what's that?
I'm just saying, oh yes, familiar.
Yeah. So here's a stat, their average out-of-pocket cost is $20 for they focus on mental and behavioral health. And, their average time to care is under 2 days from first contact for the patient and then when they completed clinical visit. That's significant. That's such great care for people who don't have that. You try to get a doctor's visit and you go to see a doctor, it's sometimes 1, 2, 3, 4 weeks or longer, or sometimes 3 months to see a provider. These guys are 2 days. This is what technology brings. This is what type of chronic care management can bring you. And they're obviously participating in the behavioral health incentives and measures that are out there. So that kind of stuff is what I get so excited about. It's the money's great, but think about the additional care quality that you're bringing to patients, the happiness that you bring into patients. Again, this is on the behavioral health side. So stuff like that. That's why I love what we do. And those who tuned in a little late, my special guest today is Greg Fulton. As my audience knows, Greg, he's a familiar voice, but he's also a long-standing healthcare strategist, writer, and expert, and always a good friend of mine. And we love to do a lot of thought leadership work together. But in the last couple minutes or so, Greg, that we have together, why don't you bring up the kind of the revenue increases that academic medical centers and other providers have seen. So I think that some of those studies I talk about, anywhere from $13,000 on average per provider per month, just for CCM. What are some of the numbers that you've seen out there?
Yeah, and I'll start also by saying we've seen a couple of studies that are recent. We can get the links out to you that also shows the healthcare costs for your patient is going to go up 75% if there is no care coordination implemented. I mean, these are basic things, and that's 75%. And yes, we've seen some studies. Let's say you're a doctor who says, well, I'm not so sure I want to do third-party contract, and I'm not so sure that I want to just, farm out the clinical staff that work on CCM. You don't have to. Nothing is mandatory about that. You can do some of the interaction with your patient. Clinical staff could do some other. All of that is up to you as how it's structured. So don't feel like it's real cut and dried on that. We did see a study in an academic medical center that kind of did it both ways. They had medical assistants conducting chronic care management. They also had NPs or nurse practitioners conducting chronic care management. And they found out revenue was only about $50 or so different, $310 versus like $370 per patient per month, based on whether it was being done in clinical staff or being done in-house. So don't feel like, if I'm doing clinical staff and I got to do a third-party contract, there goes all my reimbursement money.
Right.
No, it depends on how you scale and how you approach that business model. And that's really up to you. There's no hard and fast rules on how you would go about that. Yeah. I think the numbers we've seen bear it out.
Yeah, and I want to touch on this and then kind of move a little bit to our closing segment. But I mean, this is real money. So this is adding. I think you and I did some calculations. We're actually putting it into the thought leadership piece. You can increase your reimbursement by 3-4%, or you actually might get hit by up to 9%, 8-9% if you don't do this. So I mean, because if you add in the penalties plus the SGR cut, then the fee for service cut, then we call it sustained growth rate because we work on Capitol Hill for 20 years on helping to try to save up the SGR cuts. But that's a significant swing financially. Yeah,
going back to some of those AMA projections that we saw, you can get a cut from 4 to 9%, and they're projecting that again, 300,000 plus will via the MIPS program. Because MIPS is not going well for them. There are ways that MIPS could not be such a hardship. We believe, we're sitting here talking about it today, that chronic care management is a way to do a lot of things, jump into value-based care via MIPS being one of those. Once you have your foundations and you prove it, again, a little bit on ACOs. If you're on an ACO, chronic care management is already a benchmark in ACOs. If you're following CMS, they wanted to put our remote monitoring into it this year. They backed off and didn't because of some concerns over specialists, I should say. But chronic care management has already been within some of the ACO benchmarks as well. So it's hard to argue why not. Again, when you look at the numbers that you've been citing on the healthcare side and those things as well.
Love it. I think also kind of in closing, the importance of just starting. So I think, just looking at, your population, and again, it can be just about carving off 15, 20 patients. Look for a product that could work into your care strategy that's out there. There's a lot of great companies. What is their average ROI for their provider? I highly recommend you look at that. I don't want to promote any specific products, but specifically, there are a lot of great companies out there that do chronic care management very well. Look at the average reimbursement by the providers in your specialty. That's the important thing. It's not just generic because every specialty is very, very different. The numbers can vary tremendously. So look at that as a starting point. And again, we'll be talking about this specifically in our future thought leadership pieces. I'll turn it over to you, Greg, for the last minute or so. What are your thoughts there on the finances, on where to start?
Yeah, I would also say that you're well said by throwing out some cautions or guardrails, in approaching if you're not in chronic care management yet. Keep in mind, CMS has a lot of information that can help you out, but you have to have, for example, an electronic care plan. You have to have some EHR integration. Other than that, unlike remote monitoring, we know that chronic care management is not device driven. It's care management. It's coordinating. It's talking to your patient. Now, yes, you can multiply that up and merge that with some device-driven RPM, but there are some electronic and driven aspects of chronic care management. Don't forget about those. But the heart and soul is patient interaction and really spending that time with them, building that business model. Again, there's value-based care to be had there in the MIPS program. We'll come back with some other programs, some other advanced care models. But I just think that it makes sense, given what CMS has done last year, to at least be aware of what these possibilities are.
Totally agree. Thank you very much for that. But also, as we wrap up, I just want to say thank you very much to Greg. It's great to have you on air. We'll certainly have you back. A lot of opportunity here. We're going to do, again, this whole thought leadership series coming up. I'm excited to do it with you. Again, I won this award also because of you. You've always helped me with my writing and everything, and all of my thought leadership. So I owe a lot of that to you.
Appreciate it. Likewise.
You got it. And please, everybody, please tune in weekdays at 2:30 p.m. Eastern, 11:30 a.m. Pacific. As always, you can track me at LinkedIn at HIT Advisor, at Justin T. Barnes, also on LinkedIn and Twitter. Use the hashtag #ThisJustinRadio so we can respond to your comments from this show or any of my other shows. You can certainly see. We have everything posted. My good friend Jake Reed has posted now everything out on Apple iTunes, SoundCloud, Spotify, Spreaker, iHeartRadio, and TuneIn. So all my content now is out there. And also we published a new page, justinbarnes.com. And there's a thought leadership page on there that has all of this out there and some really great strategy on where to start for value-based care, chronic care management, and everything there. So check that out. So thanks, everyone. Have a great day.
Thanks, Justin. Good to see you.